那我们先来看一个 urine， 这是一个80岁的男生，然后他有 high grade UCT2 的 history， 那有做过 partial cystectomy， 在今年3月，好，所以他其实是 disease 的 patient。那这个 urine 应该主要的目的就会是来确认，好，他有没有 disease recurrence。那这是他做的第一套 urine 的 cytology。那我们在做 cytospin 的时候嘞，好，常常会把细胞打到边边，然后干掉了哈，所以有的时候那个湿度就是那个你简体放多少，其实有的时候会影响到啊，当然那个离心转速什么都会影响到了。好，所以其实你可以看到边边有一些细胞 preserve 不是很好啊，可是看起来好像是有问题的。好，这个形状很大，然后形状不规则，然后这个好像就看起来 NC 比较高哈，只是就是 preservation 很差。好，那遇到这种情况，当然，就是反正它就是 atypical 嘛，哈，所以打 atypical 合理，可是当然你也还是可以考虑，这个看起来就是有问题，所以是不是我们再给它多做一套，哈，有没有办法把它这个 preserve 的比较好？好，so this is the urine cytology, and then we can appreciate that there were scatter cells, the cellularity is not so high, but we definitely see some hyperchromasia, irregular cell membrane, and most importantly, it has a very high NC ratio. The chromatin pattern is not well preserved. So given the scan cellularity, I think it's appropriate that we upgrade from atypical to suspicious. So we call this urine specimen suspicious. The severity is not so high. The cell is not well preserved, but definitely there are a typical cell that was highly suspicious for high-grade urothelial carcinoma. But as you can see, it is not very preserved. The cell membrane is beating, suggests marked degeneration. So usually we won't make any interpretation out of these cells because it's degenerated. So this is what we call suspicious for high-grade urothelial carcinoma. The next specimen is a pleura effusion. The patient had a history of lung adenocarcinoma. So on low power, you can see this is hypercellularity, and you can see a lot of cell cluster into small nest. And on high power, you can appreciate the three-dimensional architecture that you need to focus up and down to see the focus of each plane. The cell demonstrates vesicular chromatin in large nuclei and with abundant cytoplasm subvacuolated, arranged in a glandular pattern. So this is a recurrence of the adenocarcinoma. And you can compare with the adjacent lymphocyte. This is markedly enlarged. So this is compatible with recurrence of the patient's long history of lung adenocarcinoma. If the patient already had a history, we won't do the TTF1. However, if the patient is a new patient, we will do a TTF1 to confirm it is primary from lung. So this is also from a patient with past history of lung adenocarcinoma. And in this specimen, you can appreciate that the background is much more inflammatory than the prior. Sorry. 喂，是你好。嘿，陶富是，嘿是，对，是，对，是，对。哎，可是我片不足不是都会把报告寄去门诊给你们吗？对， 哦，是是，对，是。啊，是。那应该是资讯是抓错了吧？是不是？啊？对对，哦，我们不足就不会写1 2 3 4 5 6 7啊。对，那茶户你把报告寄，你把号码寄给我好不好？我来确认一下好不好？然后我再回电给你。好，对，对啊，我们应该都是这样啊。不确定是发生什么问题，你把报告给我来确认。对啊，有2啊，我们都会有，因为我们不是用手写的，我们那个诊断是用点的，是点的，所以它不可能没有在前面。对，对啊，对对，哦哦哦，因为如果不是是，好，没关系，你把报告给我，我来确认。好，谢谢。你寄给我，我确认。然后我跟你讲一下，我们那天去国建署开会啊，他们国建署有说，他们从明年开始可能抹片不足也会给付，就是说他就是对，就是说我们应该不需要，对，就是他会再给我们一次给付啦，那就看他年底会不会公告。对对对。就是说，我们不要每次追回来，然后就是用同一笔去申报啦。应该以后有可能就是可以重复申报。如果第一次是不足的话，对对对，他也会不足，也会给你补助啦。对对对，意思是这样。对对对对，所以我们就看他年底会不会公告啦。因为那个国建署的有说应该可能会这样子。对，好，OK，那你寄给我确认一下，好，谢谢。不是很多啦，对，偶尔啦，对。他可能那几个，因为马利根呢，如果我们没有不是 SCC，不是 Adeno，不是什么的话，它有可能我们没有办法用那个 category 去打。可是如果你说发言或什么那些，应该不可能。对，所以你把号码寄给我，我来确认。对，好，谢谢你，谢谢，好好，拜拜。So this is much more, you show much more inflammation, even some acute one. So you can see the legionel cell is actually hiding within the dense inflammatory cell. So this is the legionel cell, and you can still appreciate this is 3 dimensional. This is vesicular chromatin, and you can appreciate this nuclei is even as big as the adjacent reactive lymphocyte. So this is adeno, and this is adenocarcinoma. So this is hiding in the inflammatory background, but still positive for adenocarcinoma. So this might be due to the treatment-related inflammation because nowadays we have a lot of immunotherapy. So these inflammatory cells can definitely attack some tumor cell, especially when there is an immune checkpoint inhibitor. However, the cancer can eventually overcome these like defense mechanism. Again, another patient with lung adenocarcinoma, and this is the pleura effusion specimen. And this specimen is also different from the prior two specimens. That we can see there are marked necrosis. So this is a highly necrotic specimen, and then you can see a lot of chorioresis admixed with inflammatory cell. But still, we can appreciate this is a three-dimensional cluster of adenocarcinoma with prominent nucleoli. The cellularity is still appreciable for diagnosis, so this is also adenocarcinoma. So this is the highly necrotic specimen, probably due to the prior treatment. So the next specimen is a pleura effusion specimen as well, but patient has a very unusual history. So this is a cytospin preparation. So as you can see, there's a ring of the cellular like a fragment at the periphery of the ring, which is due to the cytospin preparation. This is an artifact. And here we definitely see some malignant cells in cluster. It is somehow a bit epithelioid, so if you guess this is carcinoma, which is quite reasonable. But the patient actually had a prior history of undifferentiated pleomorphic sarcoma in the pleura surface. So this is a malignant specimen. We are uncertain if it is a carcinoma or it is just a high-grade malignancy. So we will call this malignant, positive for malignancy. And here you can see some single cell. This is a cell block, some single cell admixed with inflammatory debris and the fibrins. And some of them shows spindling, like a sarcomatous feature. So we would just call these positive for malignancy. And we have specimen for surgical, we have surgical biopsy specimen, and the pathology already did tons of immuno on the specimen, and it doesn't show any epithelial marker, it doesn't show any like TTF1 lineage specific marker, so it ended up with undifferentiated sarcoma. So I think this is probably the same disease, but just a little bit more epithelioid here than spindling. So we call this positive for malignancy. So let's move to ascites. So the patient has prior history of pancreatic adenocarcinoma. We received two specimens from the patient. One is only 3 millimeter, which yield negative, and this is 35 millimeters plus cell block. And in this specimen, we can see very scant adenocarcinoma cells. So here you can see this is mesothelial cells or reactive lymphocyte, and here you see a three-dimensional cluster. Pancreatic adenocarcinoma usually have lower grade of nuclear feature. So comparing to the enlarged primary lung adenocarcinoma, here we can see the size of the nuclear is basically similar or even smaller than the mesothelial cell. However, you can appreciate this is a three-dimensional pattern, which is a sign for the metastatic carcinoma. So here you can see, even though the cell is very small, you have some irregular nuclear membrane, and three-dimensional architecture increase NC ratio. So this is an adenocarcinoma. So the lesional cluster is very scant. It's not very easy to detect, but our cytotech managed to pick up some cells. And here you can see a little bit of orange color inside the cytoplasm, suggesting mucin, which is also consistent with the pancreas adenocarcinoma. And if you take a look of the cell block specimen, even though it's low cellularity, you can still appreciate here is a nice ductal architecture with like a glandular pattern, and the nuclear polymorphism is apparent. So this is a much more well differentiated adenocarcinoma in the pleura effusion specimen, in the ascites, I'm sorry. And the next specimen is a pleura effusion. The patient had a history of diffuse large B-cell lymphoma. So the specimen show a little bit drying artifact, but you can still appreciate that even though the cell show like marked dry effect, you can appreciate there are some large nucleoli in these very large looking cells. This nuclear contour is not rounded, it's angulated. So it doesn't show normal cell appearance. This cell looks malignant and is compatible with large B-cell lymphoma. And if we take a look of the loose stem preparation, again, the preparation is not optimized, but you can definitely appreciate some blastic cells that have very strange nucleoli and several small nucleoli, some attaching to the nuclear membrane, and this is a large atypical lymphocyte. And there were a couple of these in the specimen. So this looks like a involvement of a diffuse large B-cell lymphoma, and you can pay attention to these very striking enlarged nucleoli. So although the cellularity is not so high, the cellular preparation is not optimized, but we can still identify these as malignant cells. And it is compatible with the patient's history of large B-cell lymphoma, and this is the cell block preparation. So you can see majority of the cells are single cell and not in clusters. And here are some marked degeneration, but there are still some enlarged like a single cell over here. So this is positive for lymphoma. So let's move to the fine needle aspiration. The first specimen that I want to show you is a thyroid aspiration. This is fairly unusual in the thyroid aspiration because usually we will see colloid. Instead, here we see sort of like necrotic debris and inflammation. And in here, you can definitely appreciate some angulated cell with cellular process and very hyperchromatic nucleoli, and admixed in these inflammatory necrotic debris. So this is very unusual for thyroid aspiration. And if we can find some well-preserved area, for example, like here, this suggests it is a malignant specimen, and looks like an epithelioid and with marked like a necrotic debris and inflammation. So the primary diagnosis you need to think about is that if it is anaplastic thyroid carcinoma, or if it is a metastatic high-grade malignancy from other primary or directly invasion to the thyroid. So now we know we are dealing with an unusual situation. So the first thing is that we need to check the history to see if the patient had a rapidly enlarged mass in the thyroid, and if the lesion is within the thyroid, and if the patient has any prior history of malignancy from other organs. So this is the direct smear. You see marked necrosis and inflammation over here. And the lesional cell is not very easy to find due to the marked necrosis and degeneration. So Dr. Gao has do a cell block for these specimens. So in this situation, we highly rely on the cell block preparation to do additional like a confirmation of the cell origin. But here we see majority of the cellular component are actually necrotic debris, necrotic ghost cells, so which is very difficult for us to confirm the origin. And Dr. Gao has performed TTF1 PAX-A and P40. There are some positive cells for P40, which suggests that the cell may have some squamous differentiation. In thyroid, the primary squamous cell carcinoma is now considered as a variant of anaplastic thyroid carcinoma. And it can also arise from papillary thyroid carcinoma. So this is highly suggestive of high-grade malignancy and likely anaplastic thyroid carcinoma. So we diagnose the case as positive, and then we address that it's likely to be an anaplastic carcinoma in an appropriate clinical setting. So the next specimen is a breast aspiration. The patient has the prior history of invasive ductal carcinoma with mastectomy. So the clinician identified a nodular lesion on the scar of the operation site. So this is a small nodular lesion, but you can see here are some like a typical cell in cluster with prominent nucleoli and with the small like a cell nest. So the cellular component is not very apparent because there are a lot of inflammatory cells in the background. However, we can still appreciate these atypical cells, some with like eccentric nucleoli, and in cluster suggests that it is epithelial origin. So it looks like a carcinoma, and it can be compatible with the patient's prior history of ductal carcinoma. So even though we have very low cellularity, but given this type of atypical feature, I'm still comfortable to call this just positive for carcinoma. So here again, we have hyperchromatic cell in a ductal arrangement. Here as well, ductal arrangement. And because this is not from primary breast, we won't be able to see the so-called myoepithelial cell because probably there is none, suggesting that it is likely an invasive cancer, a recurrent ductal carcinoma from the operation like scar. So this is positive for carcinoma. Next, this is cytology from thyroid aspiration. The specimen is a little bit tricky because it seems to be two different populations. The first population here, you can see that it is three-dimensional, and you can appreciate here there is a cell with a single pseudo inclusion within the nuclei. So this looks like a PTC. This is a PTC. But here you also see some benign-looking follicular cells. So this aspiration actually mix quite significant portion of benign follicular cell as well as component of papillary thyroid carcinoma right adjacent to each other. So give you a very good contrast. But if you didn't screen the case thoroughly, if you only see the benign one, didn't see the malignant one, you can probably call this benign. So it is important to screen the entire specimen because in rare occasion like this, the sampling like a technique can mix two different components with papillary thyroid carcinoma as well as benign follicular cell. Sometimes the PTC area could be really scant. So you need to screen the entire specimen thoroughly and to identify the malignant component. So finally is the pap smear. The patient is a relatively young patient. She is 30-year-old. So in young patient, the prevalence of HPV infection is much higher than the elder patient. So it is common to have HPV infection, but it is not so common as the elder patient to have the intraepithelial neoplasia, because they need some time to accumulate the molecular event to become a malignant or a precursor lesion. So here we see some irregular cell with moderately increased nuclear to cytoplasmic ratio. The chromatin pattern show like a little bit like a dense chromatin, but to me, I think this specimen is a little bit difficult to appreciate. Definitely like this plastic change. So in this cluster, you can see comparing to the normal intermediate cell, it shows slightly like hyperchromasia, slightly coarse chromatin, but no pronounced increased NC ratio. The size of the nucleus is not markedly enlarged. So overall, you see some atypical cells, but it's a little bit difficult to just call it frankly dysplasia, like CO lesion. And here you see even tighter cluster, which make you a little bit difficult to appreciate the cytomorphologic feature. Adjacent, you see similar feature like hyperchromasia, slightly coarse chromatin, like a little bit irregular of the nuclear membrane. So in this situation, I think it's probably a bit difficult to just call these dysplasia out front. So I decided that it is better to call the specimen as ASCUS cannot exclude high CO, ASCH. So this is good example of ASCH. So the screener originally called it CIN2. I think it's a little bit over because there is no definite feature of CO. And the SIO doctor would like to call it dysplasia cannot exclude high CO. But for me, I think the cellular feature, you didn't find definitely low CO here, so it is also a little bit difficult to call it dysplasia cannot exclude high CO. So finally, I think ASCUS high is a good diagnosis, and it also gives the patient same follow-up strategy. The patient should be underwent colposcopy, and because it is a relatively young patient, there is a chance that it is not a CO lesion yet. So we will see. So in this specimen, we have 3 different diagnoses from 3 different people, from the clinician, from the sign-out doctor, and from me. And I think we need more evidence to definitely call this a dysplasia. So CIN2 is definitely too high. Dysplasia cannot exclude CO is acceptable, but because I didn't see any definite sign of low CO, I decided it's better to call it ASCUS cannot exclude high CO. Yeah, ASCH. So this is a category that we rarely use, but I think it's good for this situation. Okay, so this is the sign-out cases for today.
关了关了关了。
好，谢谢。好，我可以介绍，谢谢。So you were talk with the answer. I will be the moderator. I will introduce you.